Hey everyone, welcome back. I'm your host, Dr. Joseph Coppus, and I'm joined by my guest, Dr. Brett Jarosz, out in Melbourne, Australia. Thanks for joining me this morning.
Yeah, thanks for having me, Joe.
Of course. So today we are going to talk about sideline assessment to clinical assessment, and then getting players ready to play, or what it takes to get a player ready to play. Is that right?
Yeah, so we'll have a sort of discussion, I think, about the process from an athlete sustaining a suspected concussion injury, making that diagnosis from the sideline where that's relevant into the clinical assessment of that, all the way through to the management and then those clinical decisions that have to be made to get people ready to return to play.
Perfect. And you are an absolute expert in this field, so I'm excited to hear this directly from you. So before we jump into the topic, though, I'm really interested to find out more about each individual guest and what led them down their career path and why they got interested in the field that they currently practice in.
Yeah, so mine was trying to make a long story as short as possible. I was fortunate enough that I was an athlete myself, and I sustained an injury that my medical team and physicians around me, we just couldn't figure out. And through that process, one of my original mentors referred me to a sports chiropractor who was able to figure out what was wrong with me and actually got me back playing my sport. And so as soon as that happened, my process was I wanted to be him. And whatever title he was, I was going to become that job. So he had been a sports physician. I would have become a sports physician, physical therapist. So he happened to be a sports chiro. So I was like, I want to go and do what he does. So it wasn't necessarily a profession. I just wanted to be him. And then during my process in chiropractic school, when I was a fourth year student, a little bit different to how we do it in Australia, as is a 5-year university degree. And so when I was actually into my clinical rotations and seeing patients, I had a patient that was on the table who I was doing a lot of foot rehab with, and their foot issues that we were sort of progressing through from a manual therapy to all of their rehabilitation and all of their getting them back to doing the sport that they wanted to do. But this one particular day, they turned up with a headache, and they asked me if I could have a look at their neck to see if there was anything with their neck that was causing their headache. And I said, yeah, no worries, but I'm going to have a look at this foot first. We'll do all of our stuff with your foot, figure out what we need to do, and we'll progress that. And while I were on the table, I ended up manipulating their foot, and their headache instantaneously went away while I was on the table. And as a fourth year student, I had no answer for that because my world was biomechanics, orthopedics, the whole kinematic chain, but this happened instantaneously. So I went to my mentor and I said, how'd that work? And he was like, you need to speak to one of these neurochiros. And I'm like, well, what's that? I had no idea. I just wanted to be him. And through that process, I met a colleague who would study the discipline of clinical neuroscience and rehabilitation through the Carrick Institute. And down the rabbit hole we went. And so I started that journey into that clinical neuroscience world through the Carrick Institute. And then my two passions of sport and neuroscience back in, this would probably been 2012, 2013, the one topic that tied that together back then was concussion, sport and neuroscience. And of course, just the way the world has evolved over the, excuse me, the way the world has evolved over the last few years, in particular with a lot of the media attention and also the research and understanding, of course, concussions become a very, very topical conversation, and here we are today.
Yeah, and you're spot on about the rabbit hole that it is, the clinical neuroscience. But the marriage that you have of the biomechanics and the neurology, I'm sure plays a pretty pivotal role in the way you manage cases. I feel like they work pretty well hand in hand. Would you agree?
Oh, absolutely. I don't think, it's this this conceptual thing is you really, you can't have one without the other. And that's an important thing that, I know for myself, when that really hit me and you realize the two of them go hand in hand,
Mhm.
and the understanding of how those mechanics of a joint or something orthopedic, that's creating an afferent input into the nervous system, whether it's the actual, capsules, whether it's the fascia, whether it's the muscle spindles, GTOs. We've got signals that go into your nervous system. But then, of course, you've got your efferent control, things coming from cortex, things coming from brainstem reflexogenic structures into musculature, which is then in turn creating tone around a joint and creating movement around that joint. And so it's a very symbiotic relationship that we need to be looking at both of these things and understanding how the two of these things work together.
Hmm. Absolutely. And then our topic of discussion today is when that neurological system is impaired, maybe during sport or some other type of physical activity, or as you will. But what are some of the things that people are doing, kind of just sideline, baseline, to assess neurological damage in the moment?
So when it comes to suspected concussion, the first thing that's most important is that what we've got to realize, if we look at the consensus statement, and the consensus statement is up to the 5th edition now, they're supposed to meet. And obviously with everything that's going on in the world right now with COVID-19, whether or not this meeting takes place or whether they figure out how to do it virtually. But October this year, that consensus group, the concussion in sport group, will meet, and they will, have gone through all of the research again to determine whether or not there's going to be an update in the way that's best practiced for us to be assessing and managing, predicting all those different things that are associated with the field of sports-related concussion. So for us right now, we want to look at the best evidence, which is from the 5th meeting that happened in Berlin. And when we look at that, the minimum standard for us, and that's an important thing, it's the minimum standard is to be using the SCAT-5. Now, the SCAT-5 is something that people can download freely and have a look at, and all the components that are associated with that. So first step is really that recognition, and we want to be able to recognize a couple of key signs that may occur on the field of play. Dr. Jim Bovard out of Canada, he's also got a nice little segue, I guess, into also using a modified version of the SCAT-5, because he's on the sidelines for a professional soccer team. And when you look at soccer, and they're changing some of the rules this year when things get back, but they've only got 3 minutes to make a decision on the field. And if you remove a soccer football player from the field, then that player is immediately eliminated from the game.
Mm-hmm.
And of course, if you're making a decision to remove a player and they actually don't have a concussion, and let's just say it's let's say it's Messi or Ronaldo or whoever it may be, and you're removing them from play, you've potentially cost that team, a chance to win that game. So
Mm-hmm.
making that decision on field in 3 minutes is a tough task, because the SCAT-5 is going to take you 10 to 20 minutes to do.
Mm-hmm.
And ideally it's done on the sideline. So the first thing to be able to do is to recognize the injury.
Mm-hmm.
And that recognition, there are a couple of key findings that we can see. Now, the catch is whether or not you're seeing it happen live, or whether this happened behind play, and that's the importance of video replay. Now, of course, in high school sport, college sport for you guys, or in our club sports here in Australia, we may not actually have access to that video, but in the professional leagues, they do, and they can have their spotters and their medical teams see those things and recall that down to the medical staff or to the referees. So we want to look to see, did the player actually lose consciousness? Was there a ragdoll effect where the person sustained a hit and they were unconscious basically before they hit the ground, or maybe the ground impact actually made them lose consciousness? Now, I think that's an important one for anyone who does listen to this to really take away, is that loss of consciousness is only approximately 10% of all concussion cases. 90% of concussions don't lose consciousness. And that's an important thing for people to understand, because everyone thinks, oh, I didn't have a concussion, I didn't lose my consciousness. And the other important thing to remember is that you actually don't have to hit your head. You can actually be hit in your body, and that force is transmitted through the neck and the head. So a really common one that we've got to think about is a whiplash injury. So someone's sustaining a whiplash, and that biomechanics of that acceleration, deceleration injury, that if it's transferred through to the orthopedic structures in your neck, we would call that like a whiplash injury to the neck. So that acceleration, deceleration is the mechanism of injury. But basically a concussion is an acceleration, deceleration injury to your nervous system. So a whiplash and a concussion, from a mechanical, biomechanical perspective, in that mechanism of injury, are pretty much the same injury.
Mm-hmm.
It's just that one occurs primarily to your neck and the other one occurs to your nervous system. So tracing that back now, I have a whiplash mechanism of injury. Don't even hit my head. Don't lose consciousness. That could be a concussion. And our job is to then make that diagnosis of whether that is. So if they've lost consciousness, no, they're immediately removed from the field of play.
Mm-hmm.
And they're immediately removed, and you're taking them to the sideline, which we'll talk about in a second. If you see tonic posturing, there are those times where you see people get hit and maybe their arms go stiff up in the air, or their arms or legs are stiff by their body. If you see someone sustain an injury and that occurs, they're immediately removed from the field of play.
Mm-hmm.
If you see someone have an impact seizure, now the Tom Savage hit in the NFL a number of years ago literally changed the NFL rules, where he got hit and his hand was having a little seizure on the ground. It looked like a normal hit on the quarterback and he was down on the ground, but he had a seizure and that was missed. And he continued to play. And it wasn't until later on after the game that they realized that he had had a concussion. So that impact seizure and video replay became very, very paramount. So if you do see an impact seizure, they're immediately removed from the field of play. Of course, the other types of injuries where we see people get hit, they stand back up and they're like unsteady, like they're drunk or they're staggering around. That motoring coordination, sometimes referred to as staggers, sometimes referred to as ataxia. If you see that, you'll immediately remove those guys from the field of play as well. So we've got a couple of key signs that we can see. And if you just see it, immediately remove from the field of play.
Mm-hmm.
But if you don't see those things, then you've got to be able to go out onto that field or that arena, wherever they may be, and start that process of the sideline evaluation, which is where you're running through your SCAT-5 style of assessment, or the Jim Bovard. So for the listeners, I refer you guys to the British Journal of Sports Medicine. There's a podcast with Jim Bovard that was done where he breaks down his A, B, C, D, E, Fs. And it's a really nice way in the sport of soccer, where he talks about A being that alertness and attention. So is that person able to basically have a conversation with you when you run out on the field? Are they alert? Are they with it? If not, you remove them from the field of play. The B's, their behavior and balance. And you can have that quick way, like, are they staggering? Are they unsteady?
Mm-hmm.
Has their behavior changed? Another indication to remove them from the field of play. But if that's not going on, then you go and look at the cervical spine. Now, this bit here for me is an important one, because I sometimes think that we get so caught up in the assessment of concussion, but we've got to remember we have differential diagnoses that are going on too.
Mm-hmm.
So someone that's laying, if you see an actual impact, whether the person hit their head, whether they just hit their body and then they're laying down and they're unconscious on the ground, that person has a cervical spine injury until proven otherwise. And that decision, and we're making sure this person hasn't fractured their neck, dislocated their neck. Obviously, there can be some serious consequences if you are not paying attention to that person's cervical spine. So we think first aid principles there about protecting the person's neck. So someone that's unconscious, when you see an injury and they're laying on the ground and you see that impact, we think cervical spine. But if you see someone behind the field of play that just drops on the ground, one thing to go to the front of your mind is to start thinking about a cardiovascular episode. Maybe this person's had obviously significant incident as it relates to their heart.
Mm-hmm.
So a couple of little pearls there that people start thinking about. So we go back to Jim Bovard's, and you're on the field and you're running through that C, cervical spine. And then, of course, if they are alert, though, and they're talking to you and their behavior's okay and their attention seems okay, and you're making those clinical calls, you start to palpate the cervical spine and you do a quick little cervical spine screen on the field. And you're making a decision there as to whether or not there's any injuries to the actual neck. And then you've also got your cognitive things. So this is where we can start running people through their Maddox questions and like the standardized assessment of concussion. You know, where are you? Who are you playing against? You know, the day of the week, the month, and you can refer that back to the SCAT-5, which people can just type that into Google and be able to download a free PDF of that. So you got Jim Bovard's references there. You got the SCAT-5 references there that people can look up. Then Jim Bovard refers to D, which is dizziness. Now, what he has done, which I'm a personal fan of, is because we don't see this assessment in the SCAT-5 yet. And maybe with the consensus statement, we may see this come into the SCAT-6, which he throws the vestibular oculomotor screen into that dizziness section, where he will like flash lights in people's eyes to look at pupillary responses, which are very, very important. But then he'll also run through smooth pursuit, so following someone's eyes are following the doctor's thumb. He gets people to do saccades, where the fast eye movements, where he put two targets up in front and they're looking side to side, up and down. He gets them to do a thing where they look at a thumb and they move their head side to side, the VOR. He says, look at my thumb, and he brings their thumb closer into their nose, called near point convergence. He then gets them to stand up and they look at their thumb and their whole body turns side to side as a block. So their thumb, their eyes, their head are all moving as a unit. And that's called the visual motion sensitivity test. So that's a test that comes out of the research from about 2014, was where those types of testing first came into effect, and looking at that with concussion. So he throws VOMs in there, and he throws some more cerebellar testing in there. But then where I think this was the brilliant thing that he did was, again, we're relating this back to soccer, where you've got 3 minutes to make this decision on the field. And then the E was for then exertion. He goes, well, these guys are passing all these tests. I still need to know, can they stay on the field? So he gets them to quickly run across the field, 10-meter sprints, and do a few of them. And it's like, does that bring on any of your symptoms again? Does that mess up any of those tests, and quickly retest them? And then it's like, well, no. Well, now I'm going to tell you, okay, we're going to leave you out here. You've cleared all of these screening tests. It doesn't look like you've got a concussion. I'm happy for you to continue to play. But what I want you to do is, the F is for the follow-up. So if you feel any symptoms come on now, that when we return you to play and you're still on the field, if anything happens, like drop to your knee and touch your head to let us know, no, I'm not good, or put your hand up, or whatever it may be. And the other side of the F, though, of course, is then after the game, when they're off the sideline, off the field and on the sidelines, we run through our full follow-up exam, which would, of course, include the entirety of the SCAT-5. So there's that little Jim Bovard's on-field type of exam. But then when you get them onto the sideline, and that's the important thing, is you can't conduct the SCAT-5 on the field. These things have to be done on the sideline. Now, in Australia, for myself, most of the SCAT-5s are being conducted and have to be signed off by a medical practitioner. So if you're as part of a sporting team, the medical practitioner or practitioners would usually take care of that. But if you happen to be the only health provider at that, then that's your responsibility to conduct that SCAT-5. And the SCAT-5, when you look at it, it actually gives you the instructions of how to do each of the sections, but you do need practice in performing how to do it. And it literally is, it's a skill to be able to perform the entire sequence. And so we run through the SCAT-5 on the sideline, and you make that clinical decision as to whether or not you think that person has had a concussion, or then you've got to make those differential diagnoses. Are there other significant red flags here? Is there cervical spine injury? Is there a potential brain bleed? Is there like facial fractures, things like that we still have to consider there too? So that, I don't know, does that help with that sort of sideline where we're...
Oh, absolutely. Absolutely. And that brings up a couple questions, if you don't mind me backtracking to a few points that you made. Going back to Jim Bovard's ABCDs, when you're looking at eye movements and whatnot, you know, you have these medically trained professionals observing eye movements. Is there an objective measurement that they're looking at to say, okay, this saccade does not meet the standard? Does this pursuit not meet the standard? How do they determine
Yeah,
that?
that one there is something I'm very personally passionate about, and I've started some conversations with some of the concussion in sport group here in Australia
Mm-hmm.
about doing some research into this. So the VOMS, vestibular ocular motor screen, as it
Mm-hmm.
stands, is all about, does it reproduce symptoms?
Yeah.
So if I do a smooth pursuit, if I do a saccade, if I do, now near point convergence is the only one that's different because there is an objective measurement that we look for with that, which is as the thumb comes closer to the nose, do you see one eye or both eyes start to diverge? So instead of becoming cross-eyed, one eye
Mm-hmm.
basically stops coming cross-eyed and stops moving. So we can see that objectively. And there's a distance from the nose that it should be. There's some arguments out there in the literature over whether it's 6 centimeters or 5 centimeters, depending if you're an adult or a child. But right now it's 6 centimeters,
Mm-hmm.
so a bit over 2 inches. So that's the only objective one. But for me personally, the one thing about symptoms, and it is an issue with athletes, and depending on sports and contracts and professional standards, is that some athletes won't report their symptoms because they want to keep playing. Now, the thing that I like about some of these tests, that we know that when you do a smooth pursuit or when you do a saccade or when you do a VOR, and I think the VOR is a great example, if someone turns their head to one side and you're getting them to shake their head side to side really quickly, now that test is done at a 180 beats a minute. So anyone that listens to this that's never done the VOR test before, I encourage you to do it. Get a metronome on your phone, set it to 180 beats a minute, and shake your head side to side in time to the metronome while keeping your eyes on a target. A lot of people get symptoms from that.
Mm-hmm.
But if you turn your head and your eyes can't stay on the target, there's a problem with your VOR.
Absolutely.
Now, if that person doesn't report that they've got symptoms, if I see that, they're done.
Mm-hmm.
That's an objective finding to let me know that VOR is not working properly. Now, the
Mm-hmm.
only catch that we've got there, Joe, is unless you've got a pre-season or baseline, whichever label you want to give it, unless you've got an
Yeah.
exam on that, you don't know if that faulty VOR was there beforehand.
And that was my next question is, are they doing anything beforehand to try to gauge where the player is at before this to reference back after the hit?
Yeah, so if we look at the American Sports Medicine position statement, and that one came out last year,
Mm-hmm.
and that was Kimberly Harmon's group. And if you look at their study, they quote and they reference what sort of the standard baseline examinations for collegiate sport, the NCAA.
Mm-hmm.
And in Australia, I know like we have like baselines for their scats and we have baselines for their neuropsychological evaluation. And so very similar for the American Sports Medicine position statement, but they also include in there that you should have a baseline of balance. Now, again, with that, when you look at the SCAT5 has the BESS, the balance error scoring system built into it, or the modified version of it, because there's no foam testing in there. But then if we look at the literature, a lot of the literature is just sort of showing that things like one-legged standing, which is part of the BESS, there's a learning effect with that. So people can actually get better at one-legged standing just because they practice it. And this is where force plate examination is the next level. But how do you do force plate examination on the field? And so that next step of actually having to evaluate someone in the clinic afterwards. So there's all sorts of layers to it. And this is what the concussion in sport group continue to investigate, to find the best ways to help diagnose and to then obviously make that correct management decision for the health of everyone, not just obviously professional athletes, but this is anyone who sustained a concussion. But those baseline exams that's one of the hardest bits is, I don't know for yourself, Joe, but how many people come into your clinic to go, I'd like to get a baseline examination to know where I'm at before I play sport. People don't do that. People, they only come in once they're hurt. So it's one of the issues. And also to make the diagnosis of a concussion, a baseline exam is not actually required according to the consensus statement. But clinically for me, and I'm sure it'll be the same for a lot of guys who are working with the management of concussion, when it comes to making a decision to return someone to sport, it sure would be nice to know what their objective abilities were: balance, eye movements, reaction times, all of those types of things. Are they back to normal? Are they back to where their normal pre-season was? So not just the neuropsychological components, but also to, have they lost their VOR? Has their ability to balance decreased? And that to me would then make like a return to play decision a lot easier, because you can just show people the numbers. There you go. You're not there yet. But again, this is why we need more and more research. And this is why that concussion in sport group has done a great job at getting everyone together, getting the experts together to go, how do we keep getting our assessments better? How do we get our managements better? But right now we still have a lot of questions.
Yeah, absolutely. One final question about this, and then we'll move on to the clinical aspect of things. But you mentioned the SCAT-5 takes 10 to 15 minutes, correct? And then it sounds like Jim Bovard's, you might be able to do that in 3 minutes, given the soccer example. But how thorough are you really able to look at someone in 3 minutes? And do we really need to fix the assessment to fit the sport, or do we need to kind of fix the sport to accommodate for appropriate assessment?
Yeah, that's a good question, Joe. So Jim Bovard's, though, is designed so that you make the assessment on the field to make a decision whether or not you're going to remove them from the field of play, to then conduct the SCAT-5 on the sideline. So that's an important differentiation to make. It's that's happening actually on the field. So when you see that doctor out there doing whatever he's doing with the athlete, he's making the decision, especially in soccer, do I actually remove them from the field of play to run the SCAT-5? So all athletes, the doctors, the athletic trainers, the people who are out there are making that decision on the field. Do I need to remove them from the field of play? As you then said with the second part of that question, dependent upon the sport and that particular sport's rules as to whether or not you can do that. So in Australian rules football here, as an example, if a player goes down, there might be video replay that our doctors can then look at. They run out onto the field with the physiotherapist, or the physical therapist, as you guys call them. They might get a player off the field, and then they're running the SCAT-5. And if they make a determination that that athlete has not sustained a concussion, in Aussie rules football, they're allowed to return back to the field. But in soccer, that's the difference with the rule changes, is that if you remove a player from field, they've been substituted, that player's not allowed to go back out onto the field. But I do know that one of the rule changes that I believe it was in the English Premier League for this year is they were going to modify the rules to potentially have a concussion substitute to allow the actual examination. But there's all sorts of rules with soccer, and I've had the fortunate ability to chat to some of our pretty elite soccer development coaches here in Victoria, in Australia, and they were talking to me about how there's different rules with different age groups as to, up until like under 16s, I think it is that a player is allowed to be able to be removed from the field of play and then go back out there. But once you get to under 16s, those players are not allowed to go back out onto the field if they've been removed. There's also things in the junior soccer football where they're not allowed to do headering anymore because they're trying to remove those subconcussive impacts. So now in the very younger kids, and I've forgotten exactly what age it is, but definitely for kids that are like 8, 9, 10, maybe 11, 12, they're not allowed to actually perform headering in a game. They'll actually get penalized for doing that. It's actually like a foul. So yeah, there are definitely rules that are being brought in, like we got what got brought in Canada with, like, say, body checking in Pee Wee hockey.
Hmm.
And they were able to show by modifying those rules that they were able to start preventing concussion incidents. And that's, in the end, that's what this big key is. How do we prevent injuries across the board, all injuries, whether it's an ACL, whether it's a concussion injury, ankle sprains, insert whatever injury, prevention is always better than cure.
Hmm.
But the concussion prevention is definitely proving a little bit more difficult.
Yeah, absolutely. Thank you for clarifying, by the way.
Yep.
Um, so moving on to the clinical examination, your patient has had the hit on the field. You know, the sideline doc thinks there was a concussion potentially, and maybe they wind up in someone's office, maybe someone like yours. What is the appropriate assessment there then in a clinical setting?
So the person should have had the SCAT-5 done as a bare minimum. So we want to
Hmm.
make sure that one's taken care of next. And then it comes down to the practitioner and what their clinical skills and clinical training, what they've achieved and what they're able to do for that particular patient. So if we look at what the concussion in sport group have suggested, is you want to have a neurocognitive component to your exam. And there's lots of different ways to do this. You've got things like impact and cog sport, but you've also got things like C3 logics. You've also got Cambridge Brain Sciences. You've got like this EQ app. You've got the different ways to do it. You've got standard, paper and pencil outcome measures. So lots of ways you can do these neurocognitives, but of course, the neuropsychologists are the ones who are going to perform, the most detailed, lengthy battery of that. But we've got a neurocognitive panel. Then the next sort of things that you classify into your groups is you've got your vestibulo-oculomotor group.
Hmm.
So how do we assess that? Well, there's bedside things that we can do with that, with all of our different eye movement, which will include things like a VOMS. But then we've got things that we can do to further objectify that and put numbers to it. Great for patient education so they can actually see it and then they can see those dysfunctions. But things like VOG/VNG assessment, where we can measure those things like right eye tracking. You've got vestibular first goggles for spontaneous movement. There's lots of, not plugging anyone's particular equipment. It just depends on what equipment you have access to.
Hmm.
I know I'm testing one particular objective eye recording device right now for a researcher out of Europe. And I'm really looking forward to using that more, but we can objectify eye movements. We can objectify vestibular movements, and you can buy lots of bells and whistles, but in the end, it's your ability to then see
Hmm.
those deficits on people's eye movements or the various vestibular tests and understand the physiology, the neuroscience behind what that dysfunction indicates
Hmm.
and those areas of the nervous system. And to me, that then becomes the art, because identifying and triangulating where in someone's nervous system that injury may have taken place. Is it in their left brain stem, their more right cortical area, left combinations of these within their cerebellum,
Hmm.
their vestibular pathways, insert whatever.
Yeah.
We then use those objective tests within your skill sets to make a call. Is there a vestibular ocular motor injury here? The other group would be a cervical spine group. So people hear that and that becomes very interesting, right? So you go, well, the cervical spine may be involved in concussion. It's like, well, yeah. And the thing is, the next flip of that, you go, well, that sounds a bit like whiplash. But the next layer is, if someone has a whiplash, you've then got to be going in and throwing in the brain concussion things on top of it. So
Hmm.
this idea of cervical spine assessment, you've got all of your orthopedic exams that, most manual practitioners, medical doctors, all trained in to go, is that a sprain? Is that a strain?
Hmm.
Very, very simplistically. But then we've got our cervical sensory motor types of exams, and Julia Treleaven and the group out of University of Queensland here in Australia have been like world leaders in those assessments of like looking at, is there a relationship between these joints in the neck or the muscles in the neck, and that giving faulty input into someone's nervous system, where we can do joint proprioception testing, where you may see people have lasers on people's heads and they do those tests. Other tests where we put people in different neck positions and then we repeat certain eye tests to go, is the neck information then going into someone's, brainstem and reflexes area, and they're giving you faulty information. Endurance of your deep neck flexors and the ability to recruit those deep neck flexors and have endurance to be able to help stabilize your neck. So lots of different things that we can do there to look at that cervical sensory motor group. And then the final group, which I'm very passionate about, because I think it's one of those ones that gets overlooked sometimes and not performed, I think sometimes too, because this one takes some time, which is looking at the physiological group or the dysautonomia group. So far we've said we've got a cognitive group, a vestibular ocular motor group, a cervical group, and then we've got this sort of dysautonomia physiological group. And so we can do like heads up tilt table testing, heart rate variability, orthostatic vital sign testing. You've got hand grip strength and using that to look at autonomic stuff. But one of the big ones really is the Buffalo concussion treadmill test. And looking at that and looking to see a person's aerobic tolerance and their exertion tolerance. And with that test, you basically keep making a person keep going on a treadmill, and there's a certain parameters of speed and how you incline the treadmill and increase the load, basically taking the person till they fail. And what failing means is they're either completely exhausted, so their rated of perceived exhaustion is 9.5 out of 10, so they're completely incapable of going anymore, or you reproduce their symptoms. So it's a test to failure. Now that type of exam, though, as I know you guys at Neurological Wellness Institute well know this, I mean, to run through that entirety of exam for us to do a neurocognitive, vestibular ocular motor, cervical, dysautonomia, physiological, that's the concussion specific types of things. But we still have to run through also your normal cerebellar coordination testing, when you still need to run through the rest of your cranial nerve testing, your sensory exams, and the remainder of your neurological tests. You've got questionnaires about sleep-wake cycle. So like an exam for me with concussion in its entirety is about 3 hours. And I know you guys are very similar, but in order to cover all of those elements for me, that's a lengthy exam.
It is, yeah. It's exhausting
Well, it's exhausting, and for myself personally, I know I've made the decision that I break my exam up into thirds. So I do a lot of the neurocognitive stuff remotely, and that works in today's climate too, which is very fortunate. And then I actually break my exams into now 2 1-hour examinations, because as you know, some of these people, we do these exams and they need to sleep for a couple of hours after just doing one test. Some of these people are completely aggravated with all of their symptoms, and it's, and you just can't keep pushing people with these exams, and you got to give them the time to recover so you can do the exams properly.
Absolutely. Like you said, these people are very neurologically fragile. And I mean, you have to get through all this stuff to have a thorough picture of what you're dealing with, because you don't want to start treatment without having a full idea of what's going on in their nervous system. But yeah, like we said, it's very, very exhausting, especially after, some of these really bad hits. But fast forwarding then, say the rehab process is taking place, you've assessed, you've done the rehab, player wants to get back on the field. How do you feel confident that they're ready to do that? What objective measurements are you making sure you adhere to?
Yeah, it's a good point there, because I think you said the second part, which is where for us in a clinic, and with the exception, I'm involved with one professional sport where I'm there on the sidelines, but most of the stuff that I do is within a clinic. And so for me, you've got to be clinically recovered is step one. So clinical recovery, of course, is then they've got no symptoms at rest anymore.
Mm-hmm.
So the person has to be asymptomatic. And now the catch with that is if you don't have a baseline, some people may have symptoms of low-grade headache or whatever, but we could all have headache just because we've been on the screens a lot more doing online work in today's culture. So
True.
that, again, it's a clinical judgment, but we'll just keep it very black and white. You've first got to be clinically recovered. And I do want to make sure that we do mention something that's important here. But if you're dealing with children or adolescents with concussion, sports secondary. It's
That's a good point. Yeah.
It's a return to school first.
Mm-hmm.
And so sport, the actual activity of playing basketball or football or whatever it is, that's secondary, but actually doing exercise, aerobic exercise in particular, and their rehabilitation exercises, that forms part of their actual recovery and rehab. So they will be exercising, but they're just not allowed to return to playing or training at their sport until they've returned to school. So very, very important that, you know, if there's any adolescent teenagers or high school athletes that listen to this, it's return to school first. You've got to be able to be doing all of your schoolwork, all of your assignments, all of your exams. You've got to be doing all of that before you're able to return to your sport.
Yeah.
So first, you're clinically recovered. Once you're clinically recovered, you've then got your return to play protocol, which is, again, this is published in the consensus statement, but it's basically a 6-step process of you're clinically recovered, so you've got no symptoms at rest. Then you've got no symptoms when you are doing light activities of daily living, just your normal chores around the house and your work. No symptoms to do that. You have no symptoms to perform light aerobic exercise. You have no symptoms to perform sort of moderate intensity aerobic exercise with some of your sports skills in there. Maybe it's dribbling a basketball or skating with a puck or throwing and catching a football, whatever your sport is. Once you get to that point, though, and you're getting ready to return to training, and we're very specifically here talking about contact training, to return to contact training, that athlete actually needs, in Australia in particular, I don't know how it works specifically in the US, but we need medical doctor clearance. So if I work through this process, I'll talk to you about the objective things in a minute, but if we have built someone to that point that they're symptom-free, doing all of their sports training, they're lifting weights, they're running, they're kicking the ball, they're throwing the ball, they're doing all that, we need a medical doctor to then clear them to be able to return to contact training. And then once they pass that step, the medical doctor will then clear them to be able to actually return to competition.
I see.
So that's the SCAT5 return to play concussion and sport group sort of progressions. For me in clinic, I'm a little stricter because the hard bit though, of course, with this is making that decision without a true baseline. But with some of the data we have, especially like with force plates, and there's a lot of research of using, say, the modified clinical test of sensory integration and balance on a force plate where we stand people on a hard surface, eyes open and eyes closed, test their balance in those two parameters. We put them on foam, test them eyes open, eyes closed in that parameter. Lots and lots of research and a lot of normative data that exists in the research for that. And a lot of the software systems, of course, will then compare you to your age, your gender, and match you to normative data. I hold all of my athletes to 90%. I tell them that before we start. So any of the tests that I've got where I can put numbers to it, objective data that has a normative database, I hold all my athletes. You've got to be 90% or above. So whether it's all of your eye movements, and when you've got objective things on your VOG, VNG, and we know about latency of your saccades, your gain of your VOR, your gain of your smooth pursuits, all of those things, I want them 90% or better, especially if I don't have a baseline to be able to go, well, this was you beforehand, you're now there.
Yeah.
So objectively, that's what on top of the clinical stuff and the return to play stuff, I also hold my patients to the 90% profile.
Yeah, and I think that's extremely important, especially as you look forward to prevention of re-injury potential. So, the last thing you want is for somebody to clear somebody and then they wind up back in your clinic a month later. So
yeah, well, it's an interesting point to it. And so we know that one of the biggest predicting factors for any injury
mm-hmm.
is the fact that you've had that injury before.
Mm-hmm.
So if you've sustained a concussion, you are now at higher risk. Doesn't mean you will, but you're just at higher risk of being able to have a concussion again compared to someone who's never had one.
Mm-hmm.
But the other important thing as it relates to concussion is we know that if you look at multiple studies that have done this now, but a concussion, even if you've recovered from it, and again, we're using the words clinical recovery here, so you've got no more symptoms, returning back to sport, you've got like 2 to 3 times greater likelihood in that next 12 months to sustain a lower extremity injury. So to actually spraining your ankle, your risk of spraining your ankle is higher because of a concussion.
Mm-hmm.
Now, when we look at that, again, these are all hypothetical questions though. Is that because the person wasn't like objectively tested and we have like not determined that their balance actually wasn't in that 90% range? And then, so my clinical theory here is saying 90%. I don't have a big RCT research study to say, well, if you're above 90%, that risk of you spraining your ankle is lower. But if we look at other research that exists out there that shows that like ACL injuries or these just injuries, they've shown that static balance, just assessing someone on a force plate, if their ability to balance is decreased, they have a higher risk of an ACL injury. And of course, in all the ACL prevention programs, they have these neuromuscular training things that they get people to do to try and limit those ACL injuries and ankle injuries. So again, you're not sitting there specifically looking at a concussion research, but you're extrapolating from other research, which are using similar tests and similar outcomes. So again, still a lot of questions. We've got hypotheses here that we're using clinically to make clinical decisions to best serve our patients and their health.
Mm-hmm. Fantastic. Yeah, you've brought up a lot of really great points during this conversation, but we are just about out of time, and I wanted to make sure that I gave you enough time at the end in case we missed any points that you meant to make, just here at the end for the audience.
I appreciate that, Joe. I think it's such a topical conversation. Obviously, we've got a lot of media headlines too. And some of them are sensationalistic as to how media has reported some of those topics. I do just want to actually take the opportunity because the big thing here is it's about education, right? We need our patients to be educated. We need the broader community to be educated on this, and we need health providers to be better educated on it. And it doesn't mean you have to go and learn everything to be able to manage and treat concussions, but knowing colleagues and different networks so you can refer patients who have sustained a suspected concussion or a known diagnosed concussion, and you get those people into the appropriate practitioner's hands so they get the best management. But that idea of education, very important. And I can share just a little insight that I'm very excited that in the near future, I've got the opportunity through a particular group and some athletes that are in this, that there's going to be a documentary being produced on the other side of concussion to provide education, but to provide hope that there are things out there that people can do. Because a lot of the portrayal, unfortunately, of concussion is that concussion is bad and it leads to CTE. It's like this definitive concussion equals CTE, and the research that's just not true with what we know with the concussion side of it. So fortunate here that there's a documentary which will be coming out hopefully within the next 12 months, but we don't know obviously with this COVID situation.
Yeah.
But that documentary is going to be about that education and hope and giving people this idea of various assessments and treatment approaches that are out there. And for the people that are out there that may be struggling with persistent symptoms post-concussion, don't give up. go and speak to people. There are forums, there are things online. There are groups like yourself, Joe, and the Neurological Wellness Institute, the Carrick Institute. There's people out here in Australia. There's people in Europe that they've really dedicated a lot of their lives to studying, to learn more, to help serve and try and help these people. So, just to let people know out there that there is hope, and practitioners out there, just keep learning, keep serving people to the highest of your ability, and invest in yourself, and do that to help serve our patients, because there really is no higher purpose than to be able to help serve one of your fellow human people, colleagues.
Beautiful note to end on. And if anyone wanted to find more about you, or potentially this documentary that's coming out, I don't know if you can talk about it yet, but how would they do that?
Well, for myself, people can obviously find me via my name on just different social media accounts. My clinic website is optimizewithaz.chiro.com, and that's also available on social media. So obviously our rules in Australia as it relates to different things, I'm sure in due course, this information about the documentary will be making its way through various social media courses. And I'm very excited by that, because the people that are involved behind the scenes are very, very passionate to be able to help other people and provide that education to other people, which was why I was very happy to be involved with that group, because it basically served my directions and my goals as a health provider. So it matched up beautifully.
Can't wait to watch it when it comes out. But thank you again for being on and getting up this morning, to share this conversation with me. Got quite the time difference, so
yeah.
But I appreciate it.
Well, thanks for the opportunity, Joe, and hopefully the listeners can take something away from that.
I'm pretty confident they will. But thanks again, and from your host at the Neuro Wellness Podcast, this is Dr. Joe. Be well.